And with this my presentation, I hope to inform us more about the use of ultrasound in ophthalmology. So I'll be discussing, I'll have this discussion with this outline. Okay, so ultrasound waves are actually the acoustic waves greater than 20 kilohertz. But there's an inverse relationship between the frequency of the acoustic waves and the wavelength of acoustic waves. This is quite important because it forms the basis of the various types of ultrasound that we see being used in modern medicine. The higher the frequency, the shorter the wavelength. And the shorter the wavelength, the less the tissue penetration. And this gives better resolution. And this is typically what we experience with ultrasound in ophthalmology. Contrary to the use of ultrasound, for example, the abdominopelvic ultrasound, where the frequencies are actually quite lower and they have a longer wavelength and a much deeper tissue penetration to be able to access the deeper organs. And the resolution is poorer compared to the ophthalmic ultrasound resolution. This is important because when we send our patients for ultrasound scan, if they use the machine that has a very lower frequency, then we're going to get a very poorer resolution. So it's important to note this where we're sending our patients out to for ultrasound scan when we need this. So the frequencies used in ophthalmic ultrasound ranges between 8 to 10 megahertz and can even be as high as 20 to 50 megahertz in high frequency ultrasound by microscopy. The diagnostic ultrasound provides a 2D images of series of dots and lines in black and white, and it also provides a topographic information on the shape, location, extension, mobility, and gross estimation of thickness of a particular tissue. The diagnostic ophthalmic ultrasonography is very useful, especially in the presence of an opaque ocular media. And it's also very valuable in the presence of clear media, especially for evaluation of intraocular structures like iris, the lens, the ciliary body, and even the orbital structures in some peculiar disorders. Most especially, intraocular tumors could be routinely documented, measured, and differentiated by ultrasonographic techniques. So here we can see that this is the frequency ranges of sound that exist. The human hearing can only peak between this frequency of sound waves, which is between the 16 hertz to 18 kilohertz. Anything beyond that, the human hearing cannot pick that. So just a little history. There's this Italian physiologist, Lazzaro Spallanzani, and we could say he's the father of ultrasound or modern ultrasound, because in 1973 he conducted a research on bats, where he realized that bats sends out clicks, and then which are more like sound waves, and it bounces off structures, and the echoes come back, and they're able to use this to locate themselves within where they are and fly and navigate, which could be termed as echolocation. So while studying bat echolocation, he realized that ultrasound waves are being produced by these bats, and that formed the basis of modern ultrasound. And it wasn't until 1956 when Mills and Hughes first used ultrasound in ophthalmology. Later on, Baum and Greenwood developed the first two-dimensional immersion brightness mode, which was known as the beam mode scan, in 1958. And then in the early 1970s, the commercial beam scan instruments were developed by Coleman and Associates. And later on, portable contact beam scan was produced, which was introduced by Bronson. It's also very important to mention the role of Carl Osionig, who established and emphasized what we know as the standardized echography. Standardized echography provides a means of differentiating lesions through a thorough analysis. And so he developed the first standardized A-scan instruments and incorporated its use, the use of contact scan. Looking at the equipment setup, so the ultrasound setup actually starts with the probe or the transducer, which has some electric pulsar incorporated into it. And then the most important part of it is the piezoelectric crystals, which could be quartz or some other materials. So these materials actually, when they are stimulated, they produce, when they're stimulated by electric energy, they produce sound waves. And these sound waves, they vibrate and they process to produce sound waves. And in the process, the sound waves are now projected onto ocular tissues, which are now, echoes are bounced back and they're collected by this transducer. And eventually, it's sent to the receiver system, where the echoes are amplified according to the strength, and then they are now displayed on a two-dimensional projection, or maybe on the monitor. So the physics of the use of ultrasound is based on the fact that sound waves are propagated mostly as longitudinal waves, as we see in light rays, and also can be reflected, and there's also an attenuation of sound waves. What we look at when we do an ultrasound scan, we look at the echoes. So the echoes, knowing how the echoes are formed is very important. So there's something that we know as acoustic interface, which is it happens at the junction between two media, which leads to the production of the echo. So for example, sound wave is being projected from here into an ocular tissue, for example, the eyelid. So at the junction of the ear and the eyelid, these two media, there's a production of echo, which is formed by the reflection of the sound waves back to the transducer, and that is known as the acoustic interface. The ability of a medium to resist transmission of these ultrasound waves by virtue of its density is known as acoustic impedance. So the denser the medium, the stronger the echo that will probably be generated. And also the greater the difference in the sound velocities of the two media and the interface, the greater the echo as well. There are quite a number of factors that affect the echoes, like the acoustic interfaces, for example, the size, the shape, and the smoothness. So it's a small sized, an acoustic interface that has a very small size will probably produce a smaller echo compared to an acoustic interface that is large, and also the smoothness of the interface as well. Also, the incidence angle, absorption of the sound waves, reflection, scattering, and refraction occurs, and these factors, they affect the strength of the echoes. The echo is highest when the incident beam is perpendicular to the interface. This diagram here, they also try to reflect what I've just mentioned. This is a lesser dense. I hope you can see my pointer. So this is a less denser medium, and when the sound waves transmitted to this less dense medium, and the interface here, the less the density of the medium, the weaker the echo projected. Whereas in a very more dense medium, the echo is stronger. And this is also what we see. So this is more like an A-wave vector image that we're seeing here. And sound waves are being transmitted to this interface, and it is perpendicular, and that's produced the strongest echo compared to when the angle is when it's at an angle that is incident to the interface. This is just to show the various velocity of sound waves in various media. You can see it's in water, cornea, and other tissues, including silicon oil. So types of ultrasound that we know, there's the A-scan with a frequency between 6 to 15 megahertz. There's also the B-scan. A-scan stands for the amplitude scan, and while B-scan is a brightness mode. So B-scan is 8 to 10 megahertz. And there's also the high frequency B-scan, which can be up to 20 megahertz. And it's used to produce a better resolution, especially of anterior segment structures. There's also the UBM, which is known as the ultrasound biomicroscopy, and the frequency of ranges between 30 to 50 megahertz. There's a color Doppler ultrasound, various other types like the standardized echography and three-dimensional ultrasound. So the diagnostic application of ultrasound is it's very important because it's important to almost all subspecialties in ophthalmology, both the anterior and posterior segments, and even the oculoplastic as well. So the importance cannot be understated. And in talking about the A scan, which is the amplitude scan, it's a one-dimensional acoustic display. Echoes from the A scan probe are represented as a vertical spike from the baseline, which we can see here. So this is an A scan probe, and B is to scan the globe. And we can see that this here represents the spikes that we see. So these are like vector spikes that we see. So it's commonly used in the measurement of axial length. However, it can also be incorporated together with B-scan, where we see it as a vector spikes underneath the B-scan projection image. And it's also used in standardized echography together with the B-scan. While the B-scan is very popular, it's a two-dimensional acoustic sectional image, and it's indicated especially in assessment of the globe in the presence of opaque ocular media, both anterior and posterior segments opacities. Also, when there is corneal opacity, like femur, hypopyon, meioses, and can't see what's going on at the back. In presence of cataracts, vitreous hemorrhage. Other indications would include iris and ciliary body lesions, trabecular tumors, retinal detachments, and choroidal detachments, and the likes, including orbital tumors, orbital foreign bodies, and muscle inflammation as well. It is a very also important thing that I would like to stress in this presentation is the technique, examination technique, and propositioning, because it's a computerized imaging modality. The technique has to be done right to get a very accurate image that can be interpreted, and we can really use that to diagnose and work with your patients. So there's a probe. The probe has a white marker on it, as you can see in this image here. And the positioning of this marker determines the orientation of the image that is seen. So when the marker is, wherever the marker is, for example, if the marker is at 12 o'clock, then the image that you see will be, the image in that region will be on the upper border page of the image results that you're looking at. So it is important to orient this marker properly, so that one does not mistake a superior, for example, someone who has a superior retinal detachment, and the probe is oriented inferiorly to make the image look like an inferior retinal detachment. So it's important. Also, the examination technique is also important. So there's the longitudinal, there's the axial, and the transverse. In longitudinal B-scan, the marker is at the right angle to the limbus. So just like it's seen in this image. And it's mostly used to determine the anteroposterior limbs of a lesion. In the axial, the probe is centered on the cornea. Usually the marker is oriented superiorly. But if you want to do an horizontal axial measurement, then the marker has to be oriented nasally. And you can also use it so it captures the optic nerve, captures the macular region as well. And then in transverse examination, The marker is oriented to be parallel to the limbus. So it's important to know this marker orientation, and then you can now do for all the clock hours using the transverse. So these are all for contact scan, but in the immersion technique, it is better suited for an anterior segment evaluation, and that's because when you put the probe on the eye surface, on the lid when the eyes are closed, the sound waves before you can, the echoes that are picked up by the transducer on the ID do not give a very good resolution, so you don't really see all that. But if you want to examine the anterior segments, then it's better to do the immersion technique. And this allows fluid separation between the probe and the eye. Usually the probes are placed in scleral shells that filled with methyl cellulose, and then such as what we see in this image. And then you can now see that. So within here, you can see the beginning of the echo, and here, this is the methyl cellulose here. And then we can now appreciate the cornea, the iris here, the pupil here, and then, of course, the anterior capsule of the lens and then the posterior capsule of the lens. But you don't see much posterior segment structures when you're using the immersion technique. For the standardized echography, like I mentioned, which is used to differentiate lesions through thorough analysis of specific acoustic characteristics, it is the best in, and it is good we understand how it works. So it employs both the use of the A scan and the B scan. But even at that, I think one can use the B scan alone to do a standardized echography. And it entails the assessment of three properties: the topography, the quantitative characteristics of the tissue, and also the kinetic characteristics of the tissue. So in topography, you're interested in the size, the shape, is it a dome shape, is it a color buttoning, is it round, is it, and then also you're looking at the contour as well as the extensions. Does it look membranous? Is it discrete? Is it like a line? So those are the topography features that you're looking at. Then also the quantitative characteristics, it will include looking at the reflexivity. Some lesions will have low reflexivity, while some will have medium and others will have high. You will also look at the internal structure, which should reflect the density of the lesion, and also sound attenuation. If there's sound attenuation, that means that velocity of sound is reduced as it's passing through that lesion, and then that drops the echo or the brightness of the echo that is seen. Also, kinetic properties should also be assessed, which includes the tissue mobility as well as vascularity. Vascular tissues will probably be pulsatile, and you see that, and also tissue mobility as well. When patients move the eye around, does the tissue move with, does it move with the eye movement? This is very important, especially when you're trying to differentiate someone who has a retinal detachment, or perhaps a choroidal detachment, or even from a PVD. So it's important to incorporate all this. The thing is that when we do these scans ourselves, then we are able to do all this. But when we send it out, maybe a technician does it for us, and they don't report on especially the kinetic, the tissue mobility and everything, it makes interpretation of this scan results very difficult. And then, so you also have to you have to train your technicians properly so that you can rely on whatever they send back to you. I'd like to now look briefly into some of the subspecialties or areas where this scan is very helpful. This scan is important especially in the assessment of vitreoretinal diseases, to assess for vitreous opacities, bands and membranes in the vitreous and the retina. In the normal vitreous, there are no echoes in the young, maybe young individuals, but in older individuals, there may be low reflective scattered opacities, which may be normal. and this can be due to vitreous syneresis, as we know. And then also you can see a mobile posterior vitreous detachment, which may be seen as a thin line with a very low reflective spike. I'm going to show you a lot of pictures now. I'll probably be using my pointer as well so that we can follow. So this is what a B-scan image of an eye looks like in presence of PVD. This is not an axial scan because you can't see the optic nerve shadow. But this is probably a longitudinal scan. So we can see this thin hyperechoic line here, and very close to the posterior edge here, which represents the retina. And then when we combine it with the A wave, the A scan, it shows a very low reflective spike on the A scan. So it's not, and it's also a thin reflective spike. So it's a low reflective spike that it is seen. So this tells us that this is probably a tissue that is not so dense. And then the echo here that is produced at this interface is not as strong as what you see in probably other cases, like when there's a retinal detachment. So you can now say that it's probably a PVD. Meanwhile, when we look at this scan, we can see multiple bright hyperechoic opacities that are scattered within the vitreous cavity space here. And then we can now see multiple A spikes as well. And this, so it could be medium, it could be from medium to high reflective spikes that is seen, especially in cases of posterior analysis. So we're able to use this to differentiate. So I'll also show some other scans. But this is when evaluating fast rate analysis. Initially, you may use an IR gain. What I mean by gain is you increase the brightness on the scan, the scan. So when you use an IR gain, it appears very bright, and then you can now lower the gain to be sure, and you see high reflective spikes as well. Another key thing to look out for is the fact that there is a clear separation in asteroid analysis between the opacities and the retina, which is seen by this arrow here. So when there's a vitreous hemorrhage, how do you now know that this is probably a vitreous hemorrhage and it's not an asteroid analysis? So it may also, we may have to look at the A scan, the vector scan on the B scan, which we can see here. So there is a moderately high, broad reflective spike that is observed here, which corresponds to where the arrow is here. And there's also what we call like there's a gradual increase in this height of the spike, which shows that there's a bit of some blood here, and it's sending some echoes back, and we can see them as this gradual increments in spike up to the part that it gets to the most dense part of the hemorrhage, which is seen here. And it's a broader reflective spike that is seen, not the very narrow spike that we see in PVD or in the opacities from asteroid analysis. So this here is a longitudinal scan showing a retinal tear. I couldn't get the A scan of this, but what we'll see on A scan here is, so this is, we can see that there's some vitreous syneresis here, or vitreous opacities around here. And there's a bit of a line, a moderately thick band here, or a linear line here, and extending here as well, with like a curved edge here. And there's a break in continuity between these two hyperechoic lines. So this represents a retinal tear. What we'll see on A scan will be a very high reflective A spike that we'll see here. And then we'll probably see some moderate reflectivity here because of this vitreous opacity. So very low reflective spikes around here. But now, how do we now differentiate the retinal detachment from a PVD? So here on this first image, where my pointer is showing on, is actually a retinal detachment with some vitreous crisis that we can see here. One might think this looks like a PVD, but then we go back to the A scan here, and we can see that at this point here, there is a very thick membrane which should give a very high reflective spike around here compared to what we see here. The PVD may be attached to the optic disc, as we know, when it's incomplete, but what we'll see will be a very low reflecting base spike, which is seen here. So because this spike is not so high, we will not think that it's usually spike is like a retinal tissue, and that is why most likely this is a PVD. But then we have to still rely on a clinical assessments of the patients. Okay, so moving on. These are scans that we likely see in a patient with chronic retinal detachment. So this is an axial scan. We can see the optic nerve shadow here. This is a longitudinal scan here. So what we're looking at here is a chronicality with PVR changes. So with PVR, the retinal tissue shortens and then it becomes very scarred. And then the A spike that is seen is very high. It's broad. So this is like an open funnel, and while this is a closed funnel, you can also see some contraction close to the lens as well here. And here, this is a chronic, so presence of cystic echolucent spaces within the retinal tissue is a sign of chronicity retinal detachment, which we know as retinal cysts. So this is what it will look like when you have a retinal cyst. You can see the retinal tissue here is broad, it's shortened, and then we can see this echolucent cystic cavities within the tissue here. And these are retinal cysts, and this is what we've seen. Okay, so this is also another image to show so this is more like a retroalloid vitreous hemorrhage. It's not diffuse as in the first image I showed. And then we can see that, so this P corresponds to the initial spike, which is quite dense. And we can see this narrow spike, but it's not also extending up. So it's not 100% a spike. In retinal detachment, you see 100% a spike. And then we can see the arrow here, which shows very low reflective spikes of the hemorrhage, which corresponds to the aspect of the hemorrhage before we see the retinal spike here. So this is a retinal spike. Yeah. So this is also a retroalloid vitreous hemorrhage. And then for tractional bands with detachment, we can also see say linear, bright, 100% reflective spikes that will be seen on the A vector scan. And then you can see traction area here. It's some tangential pulling around here. So this is what we can, this is how an image of a tractional detachment should look like. So using the standardized scan, it makes it easy to differentiate a PVD from a retinal detachment. So when we assess for topography, a PVD has similar features with retinal detachment in the sense that it's maybe open funnel and it's maybe attached to the disc, similar to what you see in a retinal detachment. And there may also be insertion at the aura or the ciliary body. But in retinal detachment, in PVD, you will not see the features of chronicity, like PVR changes and presence of intraretinal cysts that you see in the chronic RDs. And when you look at the quantitative echography, the spikes in PVD are moderate. They are from low reflective spike to high reflective spikes, and then they're always less than 100% of reflectivity. Meanwhile, in retinal detachment, they have highly reflective spike, that's 100%. And then when you look at the kinetic echography, the PVD will demonstrate a very marked mobility to moderate, meanwhile, in retinal detachments, you hardly see mobility except it's a fresh RD, it's an acute RD, and then that's possible. So in the moderate to none mobility. So also going on, so there's something, this is also a distant image of choroidal detachment. So it also gives a very, it gives 100% spike. And then you see, so it depends on type of choroidal detachment. Is it suprachoroidal hemorrhage? Is it from effusion? So you may see, if it's due to effusion, you'll see these typical smooth bulging hyper-echoic membranes or lines with very echolucent centers around here, which shows that it's most likely due to effusion. When you see the optic nerve shadow, it depends on how the image is taken. And then what you look at is in choroidal detachment, they have very high reflectivity. It's smooth, and we have this, like this is a kissing choroidal that is here. And then you may have also, when you notice when you do the kinetic echography, the lesion is not mobile at all. So therefore that differentiates it from a retinal detachment. And this is here, you can see the arrows here showing the smooth. This is a retinal tissue and the choroid behind it. You can see a suprachoroidal hemorrhage here. This is also this kind of image of choroidal detachment. So in hemorrhagic choroidal detachment, just like I was telling us, then initially you see a very highly reflective spike, which corresponds to the retinochoroidal tissue. And then if it's due to hemorrhage, then you will now see the presence of what we call like a sound attenuation, as the sound is passed through the hemorrhage into the choroidal detachment here. So it shows as this moderate to low decreasing reflective spikes that is seen here. So this is, I said we should always look at the clinical presentation of our patients. So this is a patient who has presented with a PED. So we can see here, so PED from a wet AMD. So we can see here, so this is an area, this is a well circumscribed lesion here that is raised, and which corresponds to the region of PED. And there's a small region that adjoins it here, which is also, it's not well circumscribed. It has irregular borders. It looks as if there's some mottling around going on here. I'll do a fluorescein angiography. You can see it here in the early phase and in the mid phase. There is leakage of dye into this area, which is filling here. And there's also some leakages around there. So this is an active wet AMD with a PED component. And this is it on OCT scan. But on this scan is not commonly used for cases like this. But we may be faced with a situation we don't have any of this around. So this can help. And what we'll see will be this dome-shaped hyper-echoic line here with very sharp insertion points on the structures underneath. And then when we look at the A vector, it gives a very narrow, highly reflective spike, such as what we might observe in the choroidal detachment. But what differentiates this is when we do our on-dose photography and we do our FFA imaging, and we notice that there's leakage, which we probably not see in the choroidal detachment, if this was a choroidal detachment. And if this was an exudative retinal detachment, surface area may be wider. The other clinical features present in the patients would give us, will tell us more about what is going on. Okay, so lastly here, I have posterior staphyloma. So this is what it looks like. It's a very long eyeball with posterior bowing that is not well curved. And then, so this is the macular region, and this is the deepest parts of the retina, as we see in posterior staphyloma. So ultrasound is also important in assessment of intraocular tumors. They provide accurate measurements of tumor size, and they are very valuable for growth and regression assessments of the tumor. And standardized echography is also very important. Three-dimensional this kind of imaging, if it's possible, is very helpful, and colored Doppler imaging is very also helpful to know whether it's whether there's any vascularity of the lesion or not. The most common indication in this environment, or at least in ophthalmology, is one of them is ocular melanoma. And evaluation and measurement is very important, especially in the presence of an opaque media. But also, it's reliable. Ultrasound is very reliable when there is clear media. So it is very helpful for tumor biometry, which is important in planning for tumor management. And it entails the use of an A scan and a B scan together. So looking at when studying the acoustic properties using standardized echography, one is able to tell whether how the tumors are. And in ocular melanoma, the tumor has a solid consistency, it may be shaped as a collar button or a mushroom shape, or it may even be dome shaped, and it may be diffuse configuration, depends on the presentation. Usually there's low to medium internal reflectivity, and the lesion displays a uniform internal structure, so you don't see variability in spikes. And then also there could be the sound attenuation, and then there could be internal blood flow and vascularity. So this is a B scan, looking at image of the B scan of the patient who has this collar button hyperechoic lesion projecting into the vitreous cavity. As you can see here, with a very broad base here. So this is a very big choroidal melanoma. Now, looking at the A scan, because it's best to examine both the B and the A scan together in patients with tumors. Now we can see that this is the beginning of the tumor. We can also see some area of subretinal fluids here with retinal detachment. So this T here corresponds to the beginning of the tumor, which are also very reflective. And then this is the internal structure, as you can see here. The internal structure is relatively uniform. It's not, we don't see very variable spikes within the internal structure of the tumor. And this corresponds to the sclera here. So this is a typical large choroidal melanoma with the collar button appearance. Other appearance or presentation that might be observed would be a dome-shaped choroidal melanoma with low reflectivity and a uniform internal structure. And this is what is observed here. So this here, like I said, there's also a bit of detachment here. But this is the dome-shaped, and then this is the internal structure, as you can see here. It has a uniform echogenicity to it. And then we can see here that the internal spikes here are quite uniform. They're not very variable. Other features that might be observed in the patient who has choroidal melanoma would be choroidal excavation, as seen in this image here. So this is the beginning of the tumor here, but the tumor has excavated here, down here. So this is a retinal tissue. There's a retinal detachment here. And there's a bit of some choroidal excavation here and extension of the tumor. There may be vitreous hemorrhage or retinal detachment, and then the internal structures may be irregular, especially if it's a very large tumor that's undergoing some necrotic changes or with hemorrhage. So the tumor height and tumor base measurements using the standardized echography is very important, and using both the A and the B scan. Differentials of choroidal melanoma on B scan would be metastatic carcinoma or choroidal hemangioma. Gastric tumors may also appear like a choroidal melanoma. Other lesions like choroidal nebulous, scleral tumors, hemorrhagic PED, or even a dislocated nerve nucleus may all appear like a choroidal melanoma. So these are the distinguishing features that we see. So in a choroidal melanoma and a metastatic carcinoma that's gone to the choroid, the shape may be similar. They have a dome shape. It may even be maybe diffuse as well. But when you look at the reflectivity of the metastatic carcinoma is higher than that of the choroidal melanoma. And the internal structure of a metastatic carcinoma to the choroid is not regular as compared to a regular internal structure that is seen in choroidal melanoma. Also, there is absence of vascularity in a metastatic carcinoma. In a choroidal hemangioma as well, it has very high reflectivity, maybe a dome shape like seen in choroidal melanoma, and it has a regular internal structure. But the differentiating feature will be the fact that in choroidal melanoma, it has low to medium reflectivity, meanwhile in choroidal hemangioma, reflectivity is higher, and there's no vascularity in choroidal hemangioma. So this is a comparison between the choroidal melanoma here on the left here, and then here metastatic carcinoma here. So the reflectivity initially, so first thing is the fact that they are both dome shaped here, as you can see. But here, you can see the echogenesis here is quite uniform. This is also quite uniform, but here has more brightness to it, which reflects that you expect to see very reflective spikes here. The internal structure is not, because it's uniform, the internal structure will be also regular, and this is what is observed here. So it's quite regular, but the spike, this reflectivity is higher, even for the internal structure as well. Meanwhile, in the choroidal melanoma, it has a very low reflectivity here, and it's also uniform. Okay, so this is also, so in choroidal hemangioma, this is also seen, this is a fungus photograph in the choroidal hemangioma here. You can see the reddish elevated or circumscribed lesion here at within the macular region. It's quite big. And then we can see here on the A scan, this very reflective spikes that you can see here. And this is also what is seen in the B scan image here. And in hemorrhagic PED, so for the hemorrhagic PED, like I said, there's a sharp tip insertion. It has a smooth dome-shaped image, and then so here you have this sharp stiffness can denote where the retina is separated from. Sorry, where the RPE is separated from the choriocapillaries, as you can see here. So this is, and usually you see a very thin, highly reflective spike with low internal reflectivity, as you can see here. So it looks more like, you also one may think, oh, this may be a choroidal lesion, like a choroidal melanoma, but then very low internal reflectivity, a very high initial reflectivity that is very narrow. And then you now look at the clinical features as well. So the anterior segment tumors are also important parts of things we can examine using the B-scan. So it helps to focus, it helps us to focus on the iris and the ciliary body. Because when you can't, and it's best evaluated using the immersion technique. So when you're assessing or evaluating for anterior segment tumors, you don't do the contact technique. Ultrasound, biomicroscopy, and high frequency ultrasound is also has been greatly used to demonstrate lesions of the iris, the anterior chamber, and ciliary body. Typically, when we do the immersion technique, and in the presence of an iris lesion, which may be an iris cyst, this is what it will look like. So the B-scan can be used to differentiate solid from cystic lesions, and then also to determine the size and extent of the lesions. as we can see here. So this is an immersion technique here. This is represents the methyl cellulose, and this is the cornea here, and this is the iris. So we can see a posterior. So on the iris, there's this lesion here that is at the junction of the ciliary body. So this is an iris cyst here. And we can see there's an equivalent center, and then this is what an iris cyst looks like. It may also be. This is also another image of an iris cyst. This is the cornea here, and you can see the cystic appearance of this an equivalent center. So this is the posterior aspect of the lens. Yeah, so you can do within the stroma. So this helps differentiate whether it's a primary or a secondary iris cyst. So primary cysts are developmental, they're the most common. The echographic features will be well circumscribed and equivalent lesions that are observed on this scan. And usually you see them at the junction of the ciliary body. It is a primary cyst here. But an acquired cyst or secondary cyst, they are common after maybe trauma or surgery. And you see them usually usually on the anterior posterior iris. They're very irregular and they are well outlined as well. So this is a secondary cyst, but this is a primary cyst here. Very important disorder to look at also is the iris melanoma. Can you still hear me? How can still be heard?
Yes, I'm hearing.
Yes.
Okay, so iris melanoma can be pigmented or can be melanotic, and usually it's located either close to the angle or in the pupillary margin, and it's a solid lesion. So what you see on the B scan will be when you do an immersion technique, you will see maybe a very irregular lesion, an area that is hyperechoic and has a uniform internal structure here. As you can see, unlike the cyst where you have this equivalent center, and then usually you may see it at the edge of at the angle between the iris and the cornea, the numbers here. So this is the cornea here. You can see the posterior capsule here, and this is the iris here that you're seeing here. But at the junction between the iris here and the angle, you can see this irregular hyperechoic lesion that represents an iris melanoma. And you can see just the anterior ultrasound. But how do we now differentiate this from metastasis to the iris? So usually these are non-pigmented, and they involve the iris trauma. And what is seen here is the fact that the internal structure is not regular compared to an iris melanoma. The internal structure is not regular, so it has these varying A spikes within. So this is what it looks like on the B scan display. You can also see the location is similar to the iris melanoma, but the internal structure is not uniform. So this is more like a mixed heterogenic appearance that we see. And then and it's within the iris trauma. Also important to note that vascularity is not demonstrated. For ciliary body lesions, it's very difficult to assess because they are marked by their peripheral location. So it is best evaluated using the ultrasound biomicroscopy. Example of a ciliary body lesion that could be evaluated using a B scan is a choroidal ciliary body melanoma. It is difficult to visualize this clinically, but there are telltale features that would point to the patient having ciliary body melanoma. It's like include dilated scleral vessels. We also see an extra scleral extension. There may be a retrocapillary dome-shaped mass that is pushing the lens iris diaphragm forward. You may see subluxation of the lens, even a cataract being present. So on B scan, the ciliary body melanoma, when you do an immersion technique, you show this or a UDN, you show a smooth dome shaped. You will also be color button lesion in the ciliary body area, especially the anterior ciliary body area. And then it's confined to the anterior ciliary body, like I mentioned, but there may be an extension to the posterior aspect up to the pars plana region. So when there's a posterior extension, a contact scan may also be needed to be incorporated into the technique or using. And also presence of cystic cavities may simulate by the benign cyst. So you may see presence of cystic cavities as well. Like I mentioned, the immersion is best. So this is what looks like using both immersion and contact distance. So this is a patient who has a ciliary body melanoma. Here, so these are bubbles causing artifacts within the retinocellulose. So this is common when there are bubbles within the retinocellulose. So you see this artifacts. But then this is the cornea here, and the anterior chamber is here. The lens is here, but you can see this large hyperechoic lesion here that has the internal structure is relatively uniform, and then there's low reflectivity as is seen in choroidal melanoma as well. And then if you do a contact scan, just see a part of it here, but you don't see the full extent. So it's best to assess for ciliary body melanoma using both the immersion scan and the contact scan. It is also important to talk about, when talking about intraocular tumors, talk about pediatric tumors, especially retinoblastoma. So this kind of echography is used, very useful detection and differentiation of retinoblastoma. We know that it can be endophytic or ectophytic, and then the features that we see on this scan would include a smooth dome-shaped, maybe even irregular. There may be varying internal reflectivity due to calcification that is present, and then internal vascularity may or even be detected. So this here is a tumor here. So the retinoblastoma tumor here. You can see very bright. So the gain here has been increased. I can see this bright hyperechoic lesion that is dome-shaped, smooth. That's very internal structure or very internal reflectivity, as you can see here. And there are points, there are calcific points here, calcific changes. So when we lower the gain of the B-scan machine, then these calcifications, they remain, and then you're able to. So when you do the B-scan examination for tumors like retinoblastoma, it's important to start with an eye gain and then eventually to reduce the gain of the scan so that you can detect whether there's any calcification or not. And also other disorders like persistent aplastic primary vitreous. You can see a band, a very hyperechoic band. Also, it's important to say to note that this globe is very small. So you see microphthalmos in patients with persistent fetal vasculature, and that is what is being seen here. So there's a linear band, short axial length, and then the very, so it may be medium to high reflectivity. The band, they show medium to high reflectivity. And also in Coats disease with exudative retinal detachment, you see a localized dome-shaped elevation, a very hyperechoic elevation here, which simulates that there's a retinal detachment, and that is what is in the initial spike here. And then there's medium reflective internal structure, and this is due to presence of proteins and cholesterol causing an exudative detachment. So we don't see this low reflectivity. We expect to see a medium reflectivity of the internal structure. And it's variable, it's not uniform. Okay, so inflammatory eye disease are also a very important indication of B-scan. It plays an important role in the evaluation of inflammatory disorders, especially when inflammatory responses preclude visualization of the posterior segment, and they aid in the management and monitoring of patients as well. So common inflammatory disorders that are imaged will be places like endophthalmitis, which where uveitis, so or even non-infectious like scleritis and all other forms of uveitis. So for endophthalmitis, it is a devastating complication that can occur following trauma or intraocular surgery, and this scan is very important to determine severity and extent, and also it helps to determine the best therapeutic approach or even consideration for surgery. Whether if there's because it helps if you do this scan, you can see if it's just vitreous opacities or if there's RD, there's choroidal, that will influence your management decision. So a patient who has endophthalmitis will show this varying mixed echogenic opacities in the vitreous cavity in the presence of bands or bands, lines, bright echoes that is seen. There may be some areas of abscess that would show varying internal structures and varying reflexivity. So the presence of retinal detachment, as is seen in this arrow here as well. And that is why this scan is important. Non-infectious uveitis, which may be idiopathic, usually idiopathic or autoimmune. It may be anterior or posterior, and then contact and immersion of this scan is very important. Especially when the patient has like a fibrolytic uveitis or fibroanaphylactic. The pathology is mostly located in the anterior segment, so you may want to consider using an immersion technique. For posterior uveitis, I've seen things like vitritis, choroidal detachment, PVD. So using a B scan is also important. Also, when there's explicated nucleus or trapped nucleus, and then there's vitreous inflammation that is occurring together with it. So these are indications for B scan and things that may be present for us to look to do a B scan. So patient with sympathetic ophthalmitis with a penetrating foreign body here. So this is this very bright hypoechoic material here is intraocular foreign body causing sympathetic ophthalmitis following a patient who has a trauma. You can see presence of multiple tiny vitreous opacities here, which signifies that there's been vitritis going on in the side. And there's a shadowing due to this foreign body. As it's seen here. So this is an acoustic shadow as it's seen here. And this is typical of this is typical of intraocular foreign body. In patients with chronic uveitis with cataract and cyclitic membranes, this is what an immersion technique of the B scan of the eye will look like. There's a membrane here, so this is the cornea, the anterior chamber, don't forget. This is also the lens here. And here, you can see a membrane here. So this is not zone or anything. This is a cyclitic membrane here. In scleritis, you know that it can diffuse or nodular, it can anterior or posterior. The main echographic feature that is seen is scleral thickening. There's a diagnostic dilemma because for anterior scleritis, because it is when you look at anterior scleritis and posterior scleritis, anterior scleritis is easier to diagnose clinically, but then posterior scleritis is difficult. So the use of ultrasound to image sclera provides a very reliable means of assessment in patients who have posterior scleritis. Typically, the features will include clinically pain, inflammation, have folds, dyschedema, and echographically, the thickening of the sclera, which is seen as highly reflexive A spike with a regular and uniform internal structure. And there's this swelling of the subtemal space, and this is what gives the T sign that is seen on ultrasound. So there's swelling of the subtemal space around here. There could also on this scan we also see widening of this optic nerve shadow, and then this the tendons together with widening the optic nerve shadow, gives the T sign. That's seen in here. So this is scleral thickening as well, and this is also a scan without the. So this is not exam, so you can't see the optic nerve shadowing. So we can't see a T sign here. So also for glaucoma, it's not common because we have other better imaging techniques, but we can also use especially the UVM and color Doppler to understand certain types of glaucoma. So in a patient who has dislocation of lens into the anterior chamber, and this is what you would see, and there's pupillary block. So this is what it looks like. So it looks like here. So you can see this lens within the AC here. The AC is flat. You can't see anything here. This is the cornea where it carries. And then in a patient who has pupillary block, or maybe due to phacomorphic cataract, you can see that this is the anterior chamber is a bit narrow, and then the iris and the anterior capsule, lens capsule, are actually merged together. You can't, and so this is what it looks like in a patient who has phacomorphic glaucoma with pupillary block. So the UBM utilizes higher frequency at about 40 to 100 megahertz, requires field immersion as well to provide excellent imaging outputs with the use of eye cups. And it is mostly useful in glaucoma natural segment tumor evaluation. This is what the UBM, typical UBM scan of an anterior chamber looks like. So you can see, so it gives us like kind of a better resolution that you see in anterior segments O6s. If you can see that, you can see well the epithelial layers, the bomas, stroma, and also even the endothelium, the endothelial layer of the cornea here, the trabecular mesh is around here. This is iris. So it gives this very beautiful, good resolution when you use an UPM. But I'm not sure. I've not seen one before, so I don't know if it's really that common or if it's still being used, given the fact that we have some newer imaging modalities like the anterior segment O6s. We'll leave that for discussion later. So here also, so we can see this shows the anterior capsule here and also the iris here. So it gives this very nice resolution. And it's been used to see and assess and know more about what happens in certain forms of glaucoma. So in the patients with pupillary block with iris bombing, this is what the UBM looks like. There's an irido-trabecular contact here, and there's this bowing, actual bowing of the iris, as you can see here. So, and there's also presence of pupillary block. So this is what the UBM shows that the normal conventional B mode scan will not show. And also in patients with P2 iris, where you have this anterior displacement of the ciliary body processes. And also, you can see some degree of irido-trabecular contact as well. And this is a patient with pigment dispersion syndrome here. You can see the posterior bowing of the iris, and there seems to be acid contact with the zone moves around here. And this continuous rubbing gives us pigments that eventually blocks, causes obstruction in the trabecular mesh. And this here is a cyclodialysis cleft. So this is also showing tumors in the ciliary body and iris needles here. So for optic nerve pathology, this scan is also very amenable because it helps to evaluate the retrobulbar portion of the optic nerve. It's using topography, echography. You can see able to assess for if there's optic nerve swelling. Common optic nerve abnormalities that this scan is very helpful in distinguishing is idiopathic intracranial hypertension, optic neuritis, optic nerve tumors, cruising scleroderma. This is exhaustive. So here, so this is a normal. This is EXA and this is longitudinal scan. So this is what you see normally. This is how the V-shaped optic nerve shadow looks. In the patient who has this edema due to include subarachnoid fluid, which is seen in neuritis or compressive optic neuropathy and trauma, or even in uveal effusion syndrome, there's widening of this optic nerve shadow, as you can see here, and then maybe a donut sign. You can see. So this is what the donut sign looks like. And then clinically, you can see below this margin some tortoise vessels around the disc here, and also tortoise retinal vessels here. In optic disc drusen, there is this hyperechoic small lesion that is seen that has very high reflectivity. And initially, the scan is started with an eye gain, and then when you lower the gain, just like when you assess for calcific, proper calcific materials in the eye, it's better to lower the gain eventually, and you still see brightening of that spot. So this is what an optic drusen looks like. And in coloboma, you can see this excavation here in the optic nerve region. So this is an optic disc coloboma. Also, patients who has undergone ocular trauma may present to us with different sequelae, and especially one of them is cellulitis, and this can be used to detect and localize whether there's an abscess. Also, for guidance for needle aspiration, in case you want to send for microscopic ultra sensitivity. So this is so it's important to incorporate both the transocular and the transorbital scan. So this is the patient who has abscess, an orbital abscess here, and use it. So this is a transocular scan. This is a transorbital scan here. In transorbital scan, you don't see the vitreous cavity or any of the ocular structures. The patient has already done a CT scan, as you can see here. So you can see that the right eye has still there's a bit of a vitro bulbar collection here, and then also there's a bit of some swelling around the extension here. This is and this is seen on sagittal cuts. So in the patient who has subperiosteal hematoma as well following trauma, this is what we see. You can see this very low, very internal structure with low reflective spikes, and in the transocular as well as transocular and transorbital. But this is also transocular as well. Both of them are transocular, and this is what the CT, the coronal image of the CT looks like. So it has very low reflectivity. In presence of orbital foreign body, as in this case of a patient who has suffered a conscious injury with bullet retention in the orbital cavity, this is what we expect. You expect to see an indentation and scleral with multiple acoustic shadows that is being seen because of the bouncing of sound waves of the intraocular foreign body. I can see it on the scan with this sound attenuation as well. So most of the orbital foreign bodies are echo-dense, like glass, stones, and material. But wooden materials are very difficult to detect on this scan, especially when it's not fresh. So the longer it stays, the more difficult it is to detect on this scan. The patient who has had dislocated cataract also following trauma, this is what it looks like. And then when there's an accompanying vitritis, this is what you expect. Okay, so looking at orbits and orbital diseases, standardized echography is very useful in detecting and differentiating orbital lesions. It is good to CT and MRI. So when we look at the role of CT and MRI, CT and MRI are being used mostly. Optical ultrasound can be used in conjunction with this. The advantage of optical ultrasound is the fact that it is non-invasive. You can do it in an office setting, and it is ideal for screening to determine if you need to send a patient for an MRI or a CT. And then it helps in vivo histological architecture lesion. Also to evaluate the lesions with unusual configuration and location, and you're able to assess the kinetic properties of these lesions. You also limit exposure to radiation when you do ultrasound, optical ultrasound, especially in children, where you want to be careful of exposing them to ionizing radiations. So when you look at an ophthalmologist or a radiologist, who is better to do an ultrasound scan, well, it's good to have a very good knowledge of optical disorders. So, and also a great deal of experience. And so this helps to help guide whether this patient should go for a CT or an MRI. The limitation is the fact that the ultrasound cannot reach the orbital apex because of limited penetration. So you may have to still work with radiologists in doing compared tomography or the MRI. There are three components to orbital structures: the soft tissue, the modules, and the optic nerve. And the heterogeneity of these tissues give very highly reflective A scan and echo-dense B scan. So it is good to approach the scan as using the paraocular, the transocular, and also to combine Doppler with the contact and immersion scans. So this is a transocular, this is a paraocular here. So this is how a paraocular would look like. You're not passing through the lobe. So you probably just see orbital fibers and other structures, muscles directly. And standardized echography is very, very helpful because it tells you a lot about the lesion. So yeah, I've just put in a table showing differential diagnosis and indications. So this is there, and also for other tumors like lacrimal gland tumors and vascular tumors as well. So we've really talked a lot at length about diagnostic ultrasound or diagnostic echography. Biometry is also very important because we also use the ultrasound waves, and A-scan biometry is very important in axial length measurements. It is the most common ultrasound procedure.
So Idris, sorry to interrupt you.
Okay.
How many slides do you still have?
I'm almost done. I have less than 10 slides left.
Less than 10.
Yeah. How many minutes do I have?
You've already crossed. You're like,
oh, I've crossed. Okay.
More than.
Wow.
So I'm just thinking that is it possible to have this one later, so that the stuff will not be too much for the people that are listening.
All right,
I don't
no
know.
problem.
I'm just thinking, since this is more of this aspect you are going into now is more of therapeutic.
Yeah, well, so I'm almost done. I'm almost done. That's just 10 slides left. Just 10 slides left. Or less than 10 because it's actually up to 10.
Okay. I think people are still have knowledge of biometry compared to the ultrasound scan. So maybe you can just summarize this other part.
I just have a slide for it. Just one slide for it. That's okay.
Okay.
So should I continue?
Yes, please.
Okay, so it's the most common performed. It's important in area of power calculation and also in management of congenital glaucoma. So there are standardized axial length dimensions that have been documented from axial length biometry scans. Two techniques also exist: the contact and the immersion, and these have been used to determine what the standardized anterior chamber depth is or the corneal thickness. So I won't bore us with biometry, but it's important to also know that this is an aspect of use of ultrasound in ophthalmology. It's important to be aware that the fact that when it's retinal detachment, there'll be shortened axial length. So one has to take note of that. Also, in terms of dense cataract, there's sound attenuation and there's this impaired ability to display prominent A spike. So this can also alter the axial length. Also, when we're doing our biometry, we should consider vitreous lesions, asteroid, vitreous hemorrhage, gas or air bubble with vitreous cavity, because this may give errors of axial length calculation. Also, silicone oil erroneously elongates the eye because there's sound attenuation, and as silicone oil, as sound velocity passes through silicone oil, it has low, as sound passes through silicone oil, there's low velocity, and so this gives a false long exhalent. So you have to be careful. So this is just process of exhalent errors, short and long exhalent error measurements. So lastly, there's an aspect of new applications of ultrasound in ophthalmology. I don't know how well these aspects are being used because it's not that common around here. But they are now specially designed transducers that have been used to generate focused high intensity ultrasound through thermal effects, and these have been used for therapeutic therapeutic benefits in the use of ultrasound. So there's focused ultrasound, and this was a study was published from the Department of Ophthalmology, Columbia University, who wrote an article on focused ultrasound in ophthalmology. So ultrasound is being used not just diagnostically, but also as therapeutic means, actually to used as to treat glaucoma through ciliary destruction, just like the way we have diodes, scleral, cyclophotocoagulation, or even in treatment of tumors and other pathologies. They are also used. There's also ultrasound has also been used. There's something we know as high intensity focused ultrasound, like I mentioned. So it's also been used in other what's it called now? So this is also a study looking at therapeutic applications of ultrasound in ophthalmology. So apart from the fact that it's being used for treatment of glaucoma, there's also this ultrasonic drug delivery. There are still areas of potential research, and so people can also try to look into this. I've mentioned the fact that it can be used for partial coagulation of ciliary body, and another important aspect is the use of that we do almost every time is the cataract surgery through modern focal emulsification technique. So, and it also uses ultrasound waves to emulsify the lenses. So ultrasound has very, very wide applications in ophthalmology, and there are emerging concepts and researches going on about the use of ultrasound. So I'm almost done. It's been a long talk, and I hope I've carried everyone along. So ultrasound is a well-established diagnostic imaging modality with many wide applications in the field of medicine and surgery. The advantage is to include it's portable and the lack of use of ionized radiation, and the fact that image resolution can be limited exists for new devices makes resolution better, and the fact that there's also the 3D construction that has been available. So in summary, I'll say ultrasound will continue to provide a quality imaging for the eye and its structures, and it will always remain a viable imaging modality for many years to come. And I'm sure very soon we will welcome more information about the therapeutic uses of ultrasound in ophthalmology, apart from fiber emulsification. Thank you very much for listening. Any questions?
Thank you so much, Dr. Oyekunle, for this beautiful, well-researched presentation. We are more than grateful. I'm sure everyone that listened to you will also agree with me that it's been a wonderful session this morning. So we are very grateful. I also want us to know that we have